friends and colleagues, it's pleasure to invite you again today for the ISHKS academic program. This is the session like the previous. We have hip and knee topics, and I have a pleasure to have our managing trustee, Dr. Vikram Shah, and our patron, Dr. Pachore. Both have joined. They have been always joining in all the programs. Uh, at this juncture, I take opportunity to um, inform all of our friends, colleagues, faculties, and all the junior doctors that we have an upcoming 17th ISHKS annual meeting 2024 in Calcutta on 5th, 6th, and 7th April. The early bird registration is already open. I can tell you it's going to be a fantastic academic program, and we have a large, very eminent faculties coming from Australia, England, USA, from Germany. They're going to be live, plus the South Asian countries, Indonesia, Bangladesh, and other countries. Very eminent people from all these countries are going to come, along with, of course, our own big stalwarts, national faculties. And it's going to be very uh, useful and a very packed academic program. So please take note of this. And early bird registration is already open. There are special uh, packages for the postgraduate students. We have made it cheaper for them. So please take the benefit of that part also. After this, the main point is the today's topic. Usually we do the hip first, but this time we are doing the knee first. We have a very senior uh, and eminent knee surgeon from Mumbai, Dr. Nilen Shah. He's practicing in Mumbai for many years, and we all know him as a subvastus man. He's the one who has popularized this, practicing it very well in his routine surgeries in the knee approach. Of course, he's not going to talk on the subvastus today, but it is his pet things, and he give his talk. Welcome, Dr. Nilen.
Thank you very much, Deepak Bhai. My greetings to Dhanshekar Raja, Pachore Sab, Vikram Bhai, and to all the delegates who have joined. I will try to share my thoughts about satisfaction, although I have some problem about sharing. Okay. Can you all see my screen? Can you see my screen?
Yes, we can see the screen, sir. You just have to open the presentation. Sir, I think you've joined 2 times in the same.
Okay.
Thing. You can just leave the meeting and you can just click on leave there on the bottom.
Shall I leave?
Yes, sir. Yes, now you can share the, yes.
Okay. So you can see the first slide. Yes, everybody can see?
It's still not full screen.
Yeah.
Full screen, sir.
Yes.
Yes, sir.
Okay, friends. So ensuring satisfaction after knee replacements. So as Deepak Bhai had said, that dissatisfaction after a knee replacement is variously described up to 20% in Western literature. And there is this article in the Journal of Arthroplasty in 2019, which said this. So dissatisfaction may be knee related, where there is residual pain, restricted movement, unmet expectations, or some complication due to the knee replacement, or it could be unrelated to the knee replacement, where the pain is unrelated to the knee, or the patient has had some adverse experience. So 50% of the patients are unhappy for reasons other than the knee replacement. So I have formed rule number 1, which is that the surgeon, the primary surgeon, is responsible not just for the technical excellence of the knee replacement, but for the overall management and the experience that the patient has whilst undergoing a knee replacement. We have just had a cricket season, so we need to hit a 4 or a 6. So there are 4 things which we need to do. We need to choose the right patient, do the right surgery, be the right doctor, and ensure the right experience. So if we do these 4 things, we are hitting the ball for a 4. But if we want a 6, then we have to manage the costs in our country, and we have to manage the social aspects of knee replacements also well. So if we do all these 6 things, then we are hitting the ball out of the park. We are hitting a 6. So which patient should we be choosing? The patient must have mechanical knee arthritic pain, which is disturbing lifestyle, and X-ray shows bone on bone arthritis. There should be minimal to no extraneous factors, no claudication, no neurological factors, no hip arthritis, vascular okay, psychological factors okay, and the patient should be a good surgical candidate of an appropriate age. We should counsel the patients so that the patient's expectations match realistic results. We should judge the patient and the relatives, and we should allow buying rather than hard selling of our surgery. As many as 50% of the patients undergoing a total joint replacement have some psychological factors which can be measured by the anxiety and depression score by SF-36 or pain catastrophizing scale. And all these factors do have a bearing on the result of the knee replacement. Obviously, we cannot become psychiatrists, but we need to be aware that these things are there. So we should be able to correlate symptoms, pathology, and physical sign, spend time with the patient and relatives, operate only on genuine pathology, and we may involve other people of our team so that we get a clear picture of what the patient has. So there is this whole American Academy of Hip and Knee Surgeons symposium on the psychology of total joint arthroplasty, where it is said that patient dissatisfaction can be high because of psychological factors. And if the person is able to demonstrate resilience, then these people typically do well after the surgery. If we are operating in younger patients, we need to be aware that these people have a higher revision rate. So it is better to manage these patients with conservative measures or may consider an osteotomy. It is very well shown that the younger the patient, the lesser is the 5-year survival rate after knee replacement surgery. We have to screen the patients well. So you may involve others, but finally, in our Indian setting, it is the surgeon who is operating and has to take responsibility. There was a study done which asked the patients what is their greatest fear of patients undergoing knee replacement. So most people said that the pain in the perioperative period was their greatest fear. So surgeon needs to ensure that the post knee replacement patient is not like an accident victim. So my rule number 2 is that the surgeon is responsible not just for the long-term relief of pain, but also for pain management in the immediate perioperative period. As we all know, in our Indian setting, surgery, like birth of a baby or death in the family, is a social event. And most relatives or friends are going to visit that patient in the evening. And the opinion about the ability or lack of ability of the surgeon is formed by how that patient is feeling and performing or walking, or that patient has pain in the evening of surgery when we may be seeing other patient. So we must take responsibility and ensure that our immediate perioperative pain management is excellent. So we should have an anesthetist who is the best, but who is prepared for the worst, should remain in theater, should be time efficient, should be familiar with spinal, epidural, general anesthesia, and peripheral nerve blocks. Perioperative pain management is multimodal, patient-controlled analgesia, systemic steroids, analgesics, intra-articular cocktails, epidural, peripheral nerve blocks, femoral or adductor, and obviously the current literature and my choice is favoring adductor canal blocks. ACB, in my opinion, is a game changer where you can do an ultrasound in the theater. It can be easy but requires some training. Catheter near the femoral artery in the mid-thigh. It blocks the saphenous nerve and really produces good pain relief. And this blocks the nerve after quadriceps motor branches are given out. So there is no weakness and the patient's recovery can be dramatic, the motor recovery. We have done a lot of studies about the adductor canal blocks, and I will just share a couple of papers where this is published in the Journal of Arthroplasty, where we showed that the adductor canal block has a better functional recovery, but the pain control is similar to femoral nerve block, and that continuous adductor canal block is better than a single shot adductor canal block. Further to this, we have also started giving surgeon-administered direct adductor canal block, and we have shown that this is as good as ultrasound-guided blocks. And I have just finished a trial of ACB catheter inserted by the surgeon and compared it to the USG-guided ACB catheter inserted by the anesthetist and found that these results can also be very, very similar. So here what I am trying to emphasize is that perioperative pain management is so important that we should really put our effort and energies to make our patients comfortable. Generally, perioperative steroids were shunned by the all and sundry because it was thought that this would cause greater infection. But evidence shows that without increasing the infection risk, this can reduce pain and post-operative nausea, vomiting, and we should be using these because this makes our patient much more comfortable. Obviously, we need to do the right surgery. We need to avoid complications. And to do that, either we do a partial knee replacement or a total knee replacement. So knees that require a total knee replacement, we have to do a total knee replacement. But knees which are suitable for partial, we can do a partial knee replacement or a total knee replacement. There was a total of partial knee arthroplasty trial involving lots and lots of patients, 2019. And the recommendation from this knees trial was that partial knee replacement can offer a quicker recovery with equivalent or better Oxford knee score. So a suitable partial in suitable patients in trained hands can work well. And this was exactly the same conclusion which we had published in 1998. Anybody who's interested, this is published in British JBJS, where we showed that a suitable partial can give good results in suitable patients. So knee arthroplasty, when you are performing, you need to perform it through a suitable, adequate approach, rehearse steps, familiar team, and we should anticipate and avoid complications. An approach is a matter of choice. Personally, as Deepak Bhai said, for me, it is subvastus for all and even lateral subvastus. Whether the knee is valgus, obese, stiff, revisions or re-revisions, subvastus can be performed, and I have done it more than 15,000 times. And we have published it, our results in obese patients, in valgus knees, in stiff knees, and even in revisions. We should avoid intraoperative catastrophes, either fracture, extensor mechanism injury, MCL damage, vascular or neurological damage. So what are my tips to avoid fractures? Do adequate ligament release, use spacer blocks and not lamina spreaders. Be careful with spikes and levers and applying and removing jigs and trials. Avoid notching, no forcible hammering, and most important thing is that we need to be gentle. Very often we find that it's a young, athletic orthopedic surgeon operating on an 80-year-old or a 90-year-old, and we need to be careful because we are much more powerful than our old patients and we must avoid fractures. We should be very, very careful while inserting or removing jigs. Remove in the same direction so that we don't enlarge any of the peg holes that we have made for our implants. What are the knees at risk of soft tissue injury? Morbidly obese knees, stiff knees where there is a lot of osteophytosis, patella baja. So we need to be more careful in these kind of patients. Removal of osteophytes should be a graded exposure and release, no forcible flexion, and we need to control enthusiastic assistance so that we avoid any catastrophes. Exposure, osteophyte removal and release, these are all interlinked processes, and we should remove osteophytes before any major ligamentous releases. There can be other complications, instability, infection, patellar issues, stiffness, wound healing problems, or residual pain. It is very important to do a thorough EUA before starting the surgery. Greater is the instability of the knee, lesser should be the bone cuts. If we find that the deformity is uncorrectable, then ligament release is required. If it is correctable, then very often there is a bony defect. If the knee is lax, our bone cut should be minimal. If there is global laxity, we may need a stabilized implant. So these kind of, rather than just starting with the surgery, initially you should spend some time examining the knee under anesthesia so that you get the feel of the knee. After the bone resections, use a spacer block, move from extension and flexion and feel, and now you avoid multiple trial deductions in osteoporotic patients. I tend to preserve the PCL because I believe it is a flexion check rein, and I selectively release it to titrate the flexion gap. This can be as easy or as difficult as balancing the MCL, and different shape inserts that are now available in most systems are a big bonus. And we have presented our experience of CR knee in gross deformities as well. Now, what is a balanced knee? Very often this is different in different people's hands. So I'll just tell you what I believe is a balanced knee. It should have 1 to 2 millimeter of opening, maybe a touch more lateral than medial, 1 to 2 millimeters of forward translation, no backward translation, and just a touch of hyperextension. There should be no lift off, no squeaking, and we should be able to insert the trial insert by hand without excessive force. We should avoid malalignment. Now, there are various systems in which you can align a knee. I'm still a mechanical aligner. So for me, femoral and tibial cuts, I like to get them perpendicular to the mechanical axis. Difficult to get the femoral cut perpendicular due to the femoral bow and the head of the femur being non-palpable. Tibia is easier to feel as it is subcutaneous. So I see the merit of navigating the distal femoral cut, and the rest can be all routine. So we have navigated only the distal femoral cut and published our results in the Journal of Arthroplasty, and we showed that it can be as good in improving alignment as full navigation. Currently, robotics is available at select centers, needs additional pins in the femur and tibia. The experience is growing, but the unrealistic expectations of the patients can become counterproductive. We must avoid infection. So here also, I feel there is a little change in concept, that it is not just bad luck. We should ask the patient to decolonize from the staph by taking chlorhexidine baths. We should reduce the nasal colonization also by using mupirocin, reduce surgical time, use antibiotic loaded cement. And if you find that in the post-operative period, there is some problem with the wound healing, we should aspirate early and wash out early. So early knee infection should be treated as a make or break case. We should take cultures before antibiotics, and this should be treated as a very, very important case, not to be left to any junior. By reducing the morbidity of TK, I find that if you are not using a tourniquet, you can reduce the morbidity. You may avoid routine ICU stay, avoid urinary catheterization, reduce the need for blood transfusion, and mobilize the patients early. We have done some studies how to reduce blood loss in knee replacement. Tranexamic acid is a game changer, and we have shown that combined administration of systemic and topical tranexamic acid can be a better regime. We can use intra-articular Tranexa after capsular closure and oral Tranexa for around 3 days post-knee replacement can also reduce blood loss. So what is the right surgery? According to me, well-balanced, well-aligned, stable knee with excellent tracking, good range of movement. The knee has to be durable, may use measured resection, may navigate the distal femoral cut, may use robotics. CR or PS is a personal preference. I use subvastus tourniquet less and generally cemented knees. Now, this is very important that we need to be available for follow-up. We need to arrange more follow-ups if required, and we need to listen to our patients as to what they are saying. We may arrange patient-friendly social programs where the patients can see us as a person, as a human being, and not just as a doctor, so that the bond between patients and us is further strengthened. this symposium about patient dissatisfaction after primary total joint arthroplasty said that we must put patients first before ourselves. So to be the right doctor, we need to think from the patient's point of view. We should have empathy, genuine care that shows. We should be available. We have to listen. We have to give time. And we also need to think of costs involved for our patients. So we have to ensure the right environment. So the outpatient clinic, admission process, nursing staff, insurance, physiotherapy, junior staff, state of the hospitals, catering, all these things, although not directly under us, make a bearing as to patient satisfaction. So we should ensure that these are as good as possible. We should make arrangements so that the patients can seek help after discharge, and we have to care such that it shows. There's a Hans Christian Andersen had said that just living is not enough. One must have sunshine, freedom, and a little flower. I have paraphrased this sentence. Only doing a knee replacement is not enough. We must align, balance, and care. Patient reported outcome measures, PROMs. So there is this article which talks about a net promoter score. This is published in the British Journal of Bone and Joint Surgery, where it says that when you have done a particular procedure, after that you may have promoters who will be saying that you must go and get this procedure done by this individual. You may have detractors who say that you should never get this procedure done by you. And there will be some passives who say, yes, I have done the procedure and he's all right. So the industry, that means the car manufacturers, our Apples, Samsung telephones, all these people believe that if you have a net promoter score of 30, it is very, very good. So we put questions to our post knee replacement patients at 1 year. 2 questions. Are you satisfied? And will you recommend this doctors to others? So we did this study when the national lockdown started. We asked all our patients by a telephonic call, and we found that 95% of the patients were satisfied with a 96% net promoter score. This is unpublished data as yet. That means 860 out of 883 patients. So we should be aiming from patient satisfaction to patient delight by these tricks and the methods and the care that I have showed you. Thank you for your attention.
Dr. Nilen, it was super wonderful. I think it's your, we can say, the conclusion of your life. So 30 years of experience, you have just very nicely crafted into this, giving so many points.
Thank you.
I think you will be able to get some questions there on the chat box. But before that, I just want to ask you one question.
Sure.
You put a lot of stress on 2 points. One is the pain management, and
Yes.
second is the psychological problems. I'm going to ask Dr. Vikram Shah, the man at the Shelby Hospital. He has done some change in his practice. I'm going to come back to him after the first question to you. So, how much importance you give to the preemptive analgesia, the previous nights? Do you have a role to play in your practice?
Are you asking me or Vikram?
Yes. No, I'm asking this question to you.
See, preemptive analgesia, I am not giving. And there was a talk about giving pregabalin to our patients, and there were some reports which said that by giving that, the patient's pain is much lesser. But I did not find that helpful in my practice. And I think there was some literature which showed that if you give them Celebrex also, they are comfortable. So most of my surgeries are done under spinal, and I ensure that NSAIDs are given to the patient whilst the person is still under the effect of spinal.
So you try to break the cycle of the pain before the pain establishes.
Yes,
we do that. My second question is about your adductor canal blocked by the surgeon. Do we do with the same incision? Do we need to extend the incision proximally?
No, this is we have just finished the study on this, and without extending the incision, we have been able to put the adductor canal blocks. It's easier when you are doing a subvastus approach because the adductor membrane is just there in front of you.
Right. Okay. Fine. We'll wait for that reports to come out. Dr. Vikram Shah, I just want to ask you, I've heard you in one of the meetings that you've been giving a lot of importance to the point which Dr. Nilen has made, is psychological counseling. Can you just throw light on that?
Again, is it to Vikram or to me?
No, to Vikram. Dr. Vikram, are you on? Can you hear me?
Oh, I can hear you. What we have found over the years is that particularly Indian females are having a lot of psychological issues because of disability and a lot of social and family constraints. And these patients are hugely moneyed also. It doesn't have anything to do with money. Males don't have that big a problem. We hardly find 1% of male having problem. But 40% of females have borderline or serious issues as far as psychological issues are concerned. And some are on medicine, some are not, some because they have always found it as a taboo to go to psychiatrist and other things. So we have a full-time psychologists employed in our hospitals, and they take round of all the patients, and they find out borderline and serious patients where they need to spend more and more time, even post-operative time, and even pre-operative also they spend good amount of time. And it has helped us hugely to reduce later on repeated consultation in our office post-operatively, saying pain and discomfort and unhappiness. It has made huge difference.
Good. I think these are very two important points brought out by Dr. Vikram Shah and Dr. Nilen. Dr. Pachore, anything else you would like to add on this? Dr. Pachore, are you on the?
Deepak, can you hear me?
Yes, we can. We can.
I just want to know from all of you, what is the role of pre-operative counseling?
If you ask me, I think line what Nilen has put in his slide, please give them the realistic picture. See what is happening. We give them so much of rosy picture, which is not true all the time. So I think the most important point is, and I think Nilen has already mentioned that we don't sell this surgery to them, let them buy. That's the important point. So and so. We should try to be a little careful in field. Dr. Vikram?
Same thing. I think Nilen has summarized this fantastically, and I have nothing else to add.
So what I tell the patients is that the surgery will definitely be beneficial, but it is not magic. It will make a material difference to your life, but you will be able to live like whatever your otherwise your age and physical ability is, you will be able to live like that person.
Correct. Dr.
Nilesh,
Raja.
Okay, go ahead.
Yeah, Dr. Pachore. Carry on. Carry on.
You said the role of dexamethasone or steroid. This is just how many doses, or you just what? Or you continue for 2-3 days?
See, if you read the literature about perioperative steroids and joint replacement, I think there is no consensus in the world currently. The way I use it is that on induction, all patients get 8 milligrams of dexamethasone on induction, and they also get it the next day. In my periarticular cocktail, also I use Kenacort.
Because we just did one study at Shalvi with a prospective randomized control trial of using a single dose and 50 patients single 100 patients single dose and without. There is no question that 24 hours that there was a lot of difference in the pain, and there was also the inflammatory markers were down, the CRP, those who received the dose. So
Yes.
definitely, I think it is one of the great which one should use it when the patients are not very highly diabetic, they're very, very well controlled. So this is what is our observation recently.
So it's a single dose steroid at the time of induction, Dr. Pachore?
Yes, single dose intravenous.
Yeah, just like what Nilen said.
No, I use 2 doses.
Doctor, you give one next day also?
Yes, yes.
Correct. Okay, fine. Would you avoid this in diabetic patients?
I would generally not avoid it.
Fine.
I have not, I mean, this is now stretching my neck out a little bit. I have not had a primary knee infection for a very, very long time with whatever I am doing. And if the diabetes is reasonably controlled, I feel that it is still safe. And there are reports also which say that. There is literature to support what I am saying.
Good. Dr. Raja, are you there? Vinay?
Yes. Yes, yes. He is connected.
Okay. And Nilen, can you see any questions on your because I'm not able to see the questions.
No, I can't really see the questions. Huh?
Yeah, okay. So there is a question, CHG bath. Is Savlon soap bath is enough or you prefer CHG? Nilen?
I prefer chlorhexidine gluconate. Huh?
So I just want to add one more. There are wipes also available. If patients can take a bath, is good. But there are chlorhexidine wipes available with alcohol, which they can just wipe on the leg. That's also another good thing. Pre-operatively, if we do that, it certainly helps. Second question, Nilen, is what is your cocktail formula to reduce the pain management?
One, as I
is it
said,
the Ranawat cocktail?
I think it's a little difficult for me to offhand remember, but all patients get Kenacort, they'll get ropivacaine, and they will get an antibiotic. These 3 things.
I think with ketorolac, with adrenaline and clonidine. I think there's a Ranawat cocktail which is there. So there is another question. What is your opinion regarding Arista AH in TKR to decrease the perioperative blood loss?
Yeah, I actually just reviewed a paper. I didn't know what Arista AH was, but I was asked to review a paper about Arista AH, and they
Nilan,
compared.
let me be honest. I don't know even today. So better you tell us.
So it is some kind of mucopolysaccharide,
Okay.
which can be used the way we use tranexamic acid. So
Okay.
I had not heard of it, but as I said, just a couple of weeks ago, I was asked to review a paper. So I just read the paper, and the conclusion of that paper is that it is not better than tranexamic acid.
All right. Okay. So the last question is, if patients ask about roadmap to recovery, what will you explain then?
Yeah. So typically I say that bed rest is maybe 4 to 6 hours. They'll start walking the day of the surgery. Hospital stay post surgery is typically a day. They'll be able to go home the next day. Some people stay 2 days. It takes 6 to 8 weeks for 60 to 80% of relief from knee replacement. By that I mean that they'll have to take pretty regular paracetamol with an occasional NSAID for the first 6 to 8 weeks. But the total recovery from knee surgery is 3 months to 1 year. That's what I tell them.
Okay. Fine. Dr. Vikram Bhai, somebody asks you, when will I become normal? What will be your answer? The patient sometimes asks, when I will be मैं कब normal हो जाऊंगा, कब मैं काम कर सकूंगा? So what is your usual time period you give them, Dr. Vikram?
Is it for me or for Nilan?
No, for you. What if he has already told? So if somebody patients ask you, कि साहब मैं कब ठीक हो जाऊंगा, when I will be fit? So what is the realistic time period we give them?
You know what I answer them? Whether you are doing good or not is all in your mind. Patients who are working and looking forward to a good life, active life, they get better faster. The people who come crying in the hospital remain crying for a long time. People who come, who are looking forward to a good quality of life, they become fast, they get better faster. तो जो रोते रोते आते हैं वो लंबे टाइम रोते रहते हैं, जो हंसते हंसते आते हैं वो जल्दी हंसते हंसते जाते हैं. तो I put onus on them. I put onus on them. How well prepared you are for surgery. You want surgery or your relatives want surgery because you are burdened to them.
Correct.
So that makes my life easier, relatives' life easier, because they are also very happy because they are not able to tell that person anything.
Correct. Fine. Dr. Raja, what is the news on Dr. Vijay Bose?
He has joined already.
I'm here.
Yeah, Vijay, I think I just take opportunity to thank Nilan. It was a wonderful talk and with a good question, answer and discussion. So on behalf of Dr. Dhanashekhar Raja, my colleague, Dr. Vikram Shah, Dr. Pachore, and all the members of the ISHKS Executive Committee, we should thank you for sparing time and giving your thoughts on this. So thanks, Dr. Nilan. And Dr. Raja, can you take over and introduce Dr. Vijay Bose?
Thank you for having me.
Thanks. Okay.
I think Dhanashekhar is in the meeting. Same meeting. We are both of us in the same meeting. My apologies for joining late. So
No problem.
Dhanashekhar Raja may not be able to join.
So Vijay, I have honor to introduce you in one sentence that everybody knows Vijay Bose. I don't think I need to say anything more. It's extreme pleasure for the all of us, and I'm very sure the all young surgeons, those who have joined. So on behalf of Dr. Vikram, Dr. Pachore, and myself, and of course Dr. Raja, we thank you for accepting the invitation for this teaching program. And I know you are busy and just running between the two lecture halls. So please share your screen and your thoughts on the SCW revision part.
Thanks, Dr. for the kind introduction, and always been very close to ISHKS and Dr. Pachore in particular. Okay, so let me share my screen. It's a real opportunity for me and a privilege for being invited for this program. Thank you very much. Okay, what is this? Where is this? My thing is not coming. Yeah, got it. Can you see my slides, please?
Yes, we can.
Right, great. So today I'll be talking about the revision acetabulum, a practical guide and algorithm, what we're doing today in 2023. So most talks, we have these conferences, we have all these talks on revision acetabulum. And usually, the speaker would tell you all about the different classifications and, in detail. And also, they will also tell you about all the implants available, that's available. That's all fine. But what the trainee or the junior surgeon wants to know is what to do for a particular case, and that's really the crux of the whole thing. And not a week passes when I don't get a couple of queries by email or WhatsApp asking, sir, this is the patient and this is the revision I have, and how should I manage that? So just by knowing all the classifications and knowing all the various implants available in India today, it doesn't mean that we can, tackle a case. So the real value for knowledge is for which particular case which you can do. So when somebody sends by WhatsApp an X-ray, I tell them you do this, you do this. Now, that's not rocket science. That's based on very simple principles. And hopefully by the end of this talk, everyone will be able to, sort of gauge it for themselves. And they need not ask seniors as what to do about a particular case. So the important thing about it is the algorithm. Right. So Paprosky's classification is the one that is used almost universally. Now, the important thing about that is, there are various things. I will not go into the classification today. But the most important thing is the migration. Yeah. So when you find that, as you go up the Paprosky types, the migration gets more and more. And it becomes 3A becomes 3A up and out, and 3B is up and in, that we know. So from 2, the differentiation point between 2 and 3 is the columns are still intact in 2, although walls are deficient. But once it goes to 3, there's usually the columns are non-supportive. So that's the crux of the Paprosky classification. So the columns are intact in type 2, and as you go to type 3, the columns are distorted, and the migration, as is less than 3 centimeters in type 2, and usually more than 3 centimeters proximally in type 3. That's the essence of the classification. So if you, from what I said, type 2 means proximal migration is less than 3 centimeters, columns are intact, but walls may be deficient. And so it's divided into A, B, C based on whether the remodeling of the bone on bone loss, the circumferential remodeling, or the oblong remodeling, or the protrusio type remodeling. Type 3, we said the columns are also deficient, and 3A would be up and out, and 3B would be up and in, and type 4 represents the pelvic discontinuity. So that's very simple that we have that. So we will tackle this algorithm very simply. So Paprosky 1, we said, why is Paprosky 1? Because the migration is less than 3 centimeters. You can see the columns are all, the CT scan, the columns are all intact. Therefore, it's almost like a primary. Therefore, any standard cup you can put in a Paprosky 1, whatever cup that I used to, there's any cup will work in a Paprosky 1. So that's very simple thing to do. And that's what I have done. I used a standard primary cup, and things will, there's no bone loss, rims are intact, and there is little or no migration in Paprosky 1. Very simple thing to. Algorithm is very simple for Paprosky 1. Now, Paprosky 2, as we said, you can see the migration is now more, but the key point is it is less than 3 centimeters. So it's not a type 3, it's a type 2. Migration is less than 3 centimeters. There is certainly some wall loss there, but the columns are intact. Okay. Therefore, now, so the algorithm is that today in 2023, whenever you have a Paprosky 2, the go-to method that you're reconstructing is a jumbo cup. I will talk about jumbo cup. But so a jumbo cup by essence should be a highly porous cup. So a standard cup that you use, whether you use a Pinnacle or anything, that's not good enough. You must move into a highly porous cup because your host bone contact is going to be limited when you start using a jumbo cup concept. I'll talk about jumbo cup concept. So you can see that I've done a jumbo cup reconstruction here. How do I know it's a jumbo cup? You can see the socket on the other side. It's this socket that I have revised. It's a much bigger socket than the other side. Therefore, it's a jumbo cup. If it's a much bigger, usually about 8 to 10 millimeters bigger than the other side, then it becomes a jumbo cup. So that's the jumbo cup that we have now. So you can see it's much larger than the native size that you can see from the other side. So this is what we mean by a jumbo cup. And this is the go-to reconstruction modality whenever you have a type 2. Type 2, I told you, columns are intact, migration less than 3 centimeters. So the host bone contact in jumbo cups, you can see that, because the host bone contact can be limited, I told you need to put a highly porous cup. So you can see that typically a lot of cup would be uncovered. So the host bone contact would be limited. So it's absolutely mandatory whenever you're using the jumbo cup principle that you must use a highly porous cup. You can see in this example how much of the cup is uncovered. So with a modern highly porous cup, you can go to maybe only 60% enough. Maybe, with a tantalum cup, you can go even up to, 40%, 30% like that. So you can see another example of a Paprosky 2. Significant osteolysis is there, but migration less than centimeters. So how do I very simple. I use a jumbo cup. You can see it's much bigger than the native size of the socket. I've used a lot of uncovering is going to be there. So I used a highly porous cup, and that is a jumbo cup reconstruction again I have done. So you can see that jumbo cup reconstruction. So subtypes are there in the Paprosky classification depending on the remodeling of the bone. So the migration is less than 3 centimeters because only type 2 still. So circumferential remodeling we call 2A. If it's oblong remodeling, we call it 2B. And if it is protrusive type remodeling, we call it 2C. So all these things have been now reconstructed with the jumbo cup. Highly porous cup, put as many screws as you can. It is much larger than the other side. Now we're only dealing with the type 2 Paprosky here. So it's very simple. I think everyone got the message that the go-to option in a type 2 would be a jumbo cup. Now, what is the principle of the jumbo cup? That's very important to understand. So here is a defect. You can see, because the defect usually is superior. And therefore, the shape of the socket is much more longer in the superior inferior axis than in the AP axis. So you can see the typical defect. So a large superior inferior defect. So this would be a standard cup, but because I'm putting a jumbo cup, I'm going on expanding till I get, now what you call as a third point fixation. So now we have got the cup size now matches the larger superior inferior diameter, and therefore you have to probably remove a little bit of the anterior posterior diameter, but that's fine. 2 millimeters we remove. Now we are matching the circular socket to the large superior inferior diameter, and that's why it's called the jumbo cup, because the diameter is much larger than the native size, where both the diameters are equal. And then you put screws. And these days we recommend that you put in the lower hemisphere as well. You put in the ischium and the pubis, you can put screws, that will be great. And that's a typical jumbo cup reconstruction. And you can see that, this is a case that I've done a jumbo cup. And you can see that I'll show you the x-rays. I put inferior screws as well. So now we come to Paprosky 3. When migration is more than 3 centimeters, you can see now from the teardrop, the migration is more than 3. If it is up and out, it becomes 3A. Up and in, it becomes 3B. So an additional columnar bone, that's the key differentiating, but columnar bone loss is present. So 3A is up and out, 3A is inferior. So significant craniolateral migration indicates that the posterior column is lost. Another important tip here is we find that, it's lateral 3A. If it goes laterally, there's a posterior column loss. And if there is a craniomedial migration or type 3B, then there is an anterior column loss. So also tells you just by the x-rays what you're going to see here. So a rule of thumb is that if migration is more than 3 centimeters, one cannot get a third point by upsizing before running AP. I'll just show you this. So you will have to bring the third point down. That's the principle behind it. So here is the illustration for that. So now we say, okay, now I have now it's no more a 2 defect, it becomes 3 defect. That means there's a very large superior inferior diameter, relatively narrow AP diameter. Okay, now without knowing this, you're going to put a jumbo cup, but you run into a problem. So as you keep expanding this, trying to get a third point superiorly, you'll find that you're running out of columns here. So that's a big no-no. Because when you try to get a third point by expanding your cup size, you'll run out of AP bone. So this is a big no-no. So this is when you should not be doing a jumbo cup reconstruction. So what do? once you match the columns, once you have reached the AP diameter, you must stop. Now, since you can't go to the third point, you bring the third point down by using an augment. So that's the reason why we use augment. Because the cup cannot go and reach the third point superiorly, we bring the third point down. How do you bring it down? We use a augment, and you put screws in the augment. Okay, here is the defect. You can see that, and that's the augment that we have. You can see that it's a large defect. It's a 3A defect. Therefore, I couldn't do a jumbo cup. So I put a highly porous cup, and I brought the third point down by using a tantalum augment here. So the augments can be classified into, the methods of how we use the augment is the classical mode. You can see the, classical mode is augment is within cavity. That's the commonest mode that we use the augment. It's an oblong defect with the cavitatory bone loss, but the augment going into the bone loss area, into the cavity. And then we can put the augment there nicely, and then we can put a cup inside. So that is your classical mode of using the augment. Commonest mode, 80% of the augments, we use it in this way. Now, sometimes we can use the augments as a flying buttress. Now you find that, you put a cup like this, but you find there's a lot of uncovering of the cup. You can see a lot of uncovering of the cup. And therefore, we want to increase the host bone contact. And therefore, we put the augment like a flying buttress. That's what we do that. Okay. Now, when you have a 3B defect, usually there is significant columnar loss. And this is when we use a columnar augment or a block buttress augment. Because you don't have any bone here, we got to borrow bone from the ilium. So typically we have a flat augment that borrows bone from the ilium, otherwise called the extended fixation. We're borrowing bone from the ilium and bringing it down and bringing a support for lodging your cup inside. That's a typical block augment or your columnar augment. You can see an example in which we have used a columnar augment. Now, rarely you can use an augment as a footing where there's a lot of medial loss. You can put a couple of augments and sort of create a medial resistance to your cup. That's called the footing mode. So these are the different modes in which an augment can be used for your socket reconstruction. So when we use an augment, type 2 is a jumbo cup. Once you go to type 3, almost universally you need an augment. Now, based on the defect of the intracavitary extractor, you use the different modes of augment. But once it goes into 3A or 3B, you will need an augment. So be prepared with an augment. Now, this is something new. So the augments in theory are very fine. But there have been times when I have, opened augment. I'm sure people here who have done augments would also agree with that. But then we find it doesn't fit very well. It's too big for a patient population. So commonly screw holes do not match the area of bone stock, resulting in a very poor hole. Very commonly, it's like a jigsaw puzzle. But if you put the augment, the cup doesn't sit. You put the cup, the augment. So it's always wasting operative time, and we're not able to get a secure fixation. So we decided to solve this problem. As I said, more as I keep saying in arthroplasty, our Indian surgeons have to solve Indian problems. I'm sure, Vikram Shah is doing a lot in that aspect. And so we should all find indigenous solutions for our problems, because our population is different, our bone anatomy is different, our size is different, and the augments start with size 50. Just too big for our population. So we devised this augment known as the CCD augment, or the custom columnar docking augment, where it's a custom-made augment, which if you send a CD scan, the company will give you within 10 days. And it's really a breeze to use this. So it's based on the locking principle, and the augment will sit exactly where a defect is. There's no playing around. You put the augment, and then you put the compression screws, then you put locking screws, which because it's custom made will go exactly into the column, and you get a really fantastic 3D fixation. And then you put your dome screws, and there are typical windows for you to put it. So you get a 3D fixation. Excellent. It's actually 3D printed titanium. It's not tantalum, but gives an excellent fixation, makes your job very easy, and reduces your operative time significantly. A case example, we've done quite a few now, and you can see a pre-op plan. We used a CCD augment, and you can see how easy to do and what a rigid fixation that you get. And this is the case example. I will just go through quickly in that. It comes with a plastic model, so you can know how to fit your augment. You can see that very easily you can fit. And you can see that's how your custom augment is going to fit. And then I'm going to place that augment there. It's got K-wire holes where you can put the K-wires to stabilize the augment. And then you can screw, and because it's custom made, it'll go right into the column. And these are long locking screws. And now you see in a second that they'll also tell you what screws to use. So it comes with a PDF, and you can actually find out what screw to use for which length to use. You can see that exactly this screw hole, you must use a 50 millimeter screw, etc. And it's very safe also because the direction is prefixed. And so it's a very elegant way to use these days the augment. Yeah. Now we come to the last bit of it, the Paprosky 4 or the pelvic discontinuity. So how do you make out pelvic discontinuity on the X-ray? You look for these X-ray features. You have a transverse fracture line. You have medial translation of the inferior portion of the pelvis. There's a break in the ilioischial line. There may be a rotation of the hemipelvis. And there's an asymmetric obturator foramen. All these are clues to say that, hey, I'm dealing with the pelvic discontinuity. It's very important to pick up pelvic discontinuity. And sometimes the X-rays are actually better than CT scans to pick up pelvic discontinuity. Then your whole game plan changes. So typically in a revision situation, you cannot plate the columns because it occurs over a slow process. It's a chronic non-union. So you cannot say, I'll plate this column and try and get this thing about it. Yeah. So we have the three options available for our thing. One is a cup cage or a cup half cage construct, a cup in a distraction mode, or a custom tri-flange cup. So your entire option changes. So Paprosky 2, jumbo cup. Paprosky 3, you have to use an augment. Paprosky 4, those options go out. These are the three options that you have. I'll talk a little bit about this. And it's not going. Okay. So this is the algorithm for pelvic discontinuity. As you can see, if the 3 points are mobile, then it has been made stable by fixation or by distraction. Okay, we talked about the 3-point fixation in the cup. They are mobile in a pelvic discontinuity. That's the problem. So the first fundamental concept is there to make them stable by either fixing it or by distraction mode. Yeah. So you find that if the cup is stable with a large press fit using a large cup, then usually we underream by 5-6 millimeters, sometimes 3 millimeters. And therefore we distract the whole thing so that the fibrous tissue distracts and the whole thing now becomes stable. So then you have to put screws in both the hemispheres and then that works. So that will be the easiest thing to use. You use a large cup, which you use the distraction mode. You can put a pelvic distractor, or you can do it without a distractor also, where you put a large cup, you underream by 4-5 millimeters, and you're able to distract this non-union into a stable construct. Then if this does not work, then you're looking at a cup cage construct. Okay, I'll talk a little bit about the cup cage construct. And if that also you find is not possible, then you have no other choice but to have a custom-made tri-flange cup. This is the standard protocol anywhere in the world. Now, thing about the thing is, suppose if there is a acetabular fracture with a discontinuity, then you have to plate the posterior column. That we know. So if we have an acute situation like this, then you plate the posterior column, then you can put a cup like this, a BS cup like this. But a cup cage construct, many people misunderstand. They just put a standard cage and call the cup cage construct. That is not true. The cup cage construct, the first thing that you have to put in is a large cup, a large TM cup or highly porous cup, and get bihemispherical fixation first. So this is like a bone graft. This acts like a bone graft. And over this cup, you are bringing a cage, not the other way around. Over the cup, you're bringing a cage now. Now, this cage is to protect this cup from dislodging, from mechanical forces. So this cup stays like you put for bone graft, you put for the cup so that the cup is deloaded from mechanical forces and the cup can osseointegrate. And then you put your polyliner in. That's how a cup cage construct works. Now, remember that the BS cage, the Berschneider cage that is available in India, the Zimmer does not give you the specific cages. So it's 50 millimeters. Therefore, the cup that you must put must be a minimum 66 millimeters before you can think of a cup cage. Many times in conference, people say, I did a cup cage construct. Cup cage construct in India cannot be done unless your cup is a minimum 66. This was described by and published by Dr. Rajesh Malhotra. So we have now covered all this. So type 2 is circumferential remodeling, jumbo cup reconstruction. Type 3, more than 3 centimeters up. Then you need an augment because you can't go to the third point. You're bringing the third point down. But you got to recognize pelvic discontinuity. If pelvic discontinuity is there, I told you the algorithm for pelvic discontinuity. So with this algorithm, any revision can be tackled well. You can yourself, there's no need to get expert opinion. You can find out what to do for a particular case and you can execute your plan. Thanks. I'll stop sharing now.
Thank you, Vijay. By the time you see some questions on the chat, I just want to ask, when you use the augment which you showed, what is the protocol for the weight bearing? How does it changes?
Well, like in any augment and a complex reconstruction, you need to have 6 weeks of partial weight bearing or toe touch weight bearing till it integrates, because we want to deload this. We don't want load acting immediately on that. And once the osseointegration occurs, osseointegration occurs very rapidly because these are 3D printed tantalum like augments, so very rapid augment. Then you can start weight bearing on that.
Yeah. Yes, personally, we have heard you number of times in the conferences, but for the benefit of the young colleagues, those who have joined here, just want to know your opinion. Instead of augments, you always say that bone grafting or a large chunk of a femoral head bone graft is not a good option. Can you just comment?
Yes. So, earlier on the concept before the augments, structural bone grafting. So don't get me wrong. So when you want to fill up, for example, protrusio, some bone, that's all fine. That's all not structural bone graft. But when you do a structural bone graft, and that by structural bone graft, by definition means if that bone graft does not osseointegrate, your whole concept will fail. That's a structural bone graft. So when you use a structural bone graft, the success rate is limited, especially in the medium term. So it seems to work well, but at about 5 to 7 years, they all fail. And so Alan Gross, who has done more, structural bone grafting than anybody, Alan Gross himself has said, you must not do structural bone grafting in arthroplasty on the socket side. The only exception is when you have a post-acetabular fracture situation, you're doing an arthroplasty, when you have the own femoral autograft. So we will never have autograft, for obvious reasons. But when you have the autograft femoral head, it works very well. Not allograft. Autograft, post-acetabular fracture, you're doing that structural graft works very well. But apart from that, if you use a structural graft, the chance of failure is very, very high. So we have all moved on to world over. We have moved to usage of augments. It's a much more reliable fixation that we get than structural bone grafts.
Dr. Pachore, we need your...
Vijay,
yes, Dr. Pachore.
It was a great talk. I learned quite a lot of things and you made it very simple for the people. Absolutely fantastic talk. I must congratulate you.
Thank you so much, Dr. Pachore.
And just wanted to know what is your experience with this Exatec, because every time the Gmer is not available cup and cage, what about the role of Exatec, which is uncemented, which has got flanges, which has got a hook, and it probably we use it for pelvic dissociation. What you mentioned was Proprosky 4. What's your thoughts on that?
Well, this is the Peter Braum cage, and I've been to Peter Braum and all the designers, and they very clearly say that you must not use it in pelvic discontinuity. It's not meant to be discontinuity. So what we follow now in India is the American school of thought, where we, when there's a type 3 defect, we generally use a cup and an augment. But the German philosophy is that they will use something like a cage here, an osseointegrating cage. This is an alternative for using augment in type 3 Peprosky. It is not for pelvic discontinuity. It's a very, very important point here. So we should not be using it in pelvic discontinuity. But if that's your philosophy of that you have to use an osseointegrating cage instead of an augment, German philosophy, that's fine. You can use it, but it does not. And especially in a protrusio type situation, and when you have protrusio type, I find that Exatec cage very useful. Peter Braum actually, but certainly not for a Peprosky 4, not for pelvic discontinuity. And the designers themselves say that very clearly. Yeah, there's no ambiguity about it. Yeah.
Vijay, can you look at the chat, or shall I ask the question? What has been written?
Yeah, please ask the question. Yeah. I'll also look at the chat. Yeah.
In case of socket size being 46 mm with pelvic discontinuity, how can we reconstruct such cases as cup cage can be used with 60 mm only?
You cannot. That's why a cup cage cannot be used. So if it is 46, you try and see whether you can get an endpoint. The distraction, you can get an endpoint. If you want to do it in a controlled manner, you use a pelvic distractor, put 2 screws across the discontinuity and distractor, and then you see whether there's an endpoint. If there's no endpoint, then that option will not work. If there's an endpoint, say it distracts 4, 5, 6 millimeters, that's great. Then you put a big cup inside. And then once you take the distractor off, it will all collapse back into again. Or you can gently ream and 5, 6 millimeters less and gently tap your cup. The cup itself will distract your pelvis. Distraction. That means there's fibrous tissue at the non-union level, at the pelvic discontinuity level. That will work well. But if that doesn't occur, then you're basically looking at a custom tri-flange cup. Because For our patients, this cup cage construct is almost impossible because we need a 66 cup. That's huge. Some male patients, we may get away with it, but for most patients, availability, because we don't have the Zimmer cage with us, we are stuck. We cannot use it for our patients.
Yeah, another question is for the CCD augments.
Yeah.
Do we need to send them the the CT scan CD, and to whom to contact?
Yeah, the website is there. It's the Jajal Medical. Online, you can go and you have to upload your CT. And the lead time is 10 days. So they'll give you the augment within 10 days. And then you can put the augment in. Yeah. So it's all online now. There's no need for sending a CD and all that. Yeah.
Dr. Pachore?
No, that's okay. That's okay.
Yeah.
There's another question saying any particular size that can be labeled jumbo cup. So this is what I know. I'm very fond, that we're all following the American principle, but our sizes are all different, So we cannot call that, American definition is more than 60 size is a jumbo cup. But we can have a jolly well 50 cup than a jumbo cup. So generally, it's about, it's 6 millimeters more than your cup, a native cup on the other side. Then it can jumbo cup. So it's a principle that matters, that you're expanding, the AP diameter to match the large superior inferior diameter. That's the jumbo cup principle, but real size doesn't matter. So what is the other to whom to call? Okay, that we have answered. And label jumbo cup. So the principle you have to understand what is in a jumbo cup.
And the more porous material you use in type 2, so you're talking about gription or tantalum cup.
That's correct. That's correct.
Type
Yeah.
2 with multi-hole.
Multi-hole is also very important, but the idea of using a highly porous cup is the amount of, for example, use a standard cup, say using Pinnacle. Pinnacle may need up to 75 to 80% of host bone contact for it to survive. But once you start using gription, the host bone contact can be 60 or 50. So that's a huge advantage for you. So you've got to bring it down. Now using tantalum cups, people say you can go up to 30%. Only 30% of host bone contact is enough. It's still osseointegrate. Yeah. So, the more, in the highly porous it is, the less is your host bone contact required for long-term success.
Dr. Pachore, your opinion on tantalum material, what is your experience?
I think there's no question that what he mentioned, there's a lot of frictional resistance which has got this tantalum cup, and they will osteointegrate very rapidly. There's no question. Only the problem is the cost factor, but we don't consider the cost factor for the patient, actually. So definitely when the host bone contact is less than 50%, maybe I would go for 60%, not the 30%, what Vijay said. But then the use of tantalum cup is much better choice.
Yeah, Vikram wants to say something. Yeah.
Tantalum is a heavier metal than titanium, and Zimmer has a patent for it. So they are making tantalum related knee and hip augments. Rest of the companies are making titanium selective laser melting.
Yeah, you can 3D. It's easier to make 3D printed now. So even the CCD augments are 3D printed. Now the Zimmer has got a patent. The patent has actually expired. Not only a patent, it has got, they can manufacture only in one facility in the US because highly explosive.
New Jersey. I have seen that factory.
Correct, yeah.
I have seen that factory 10, 15 years back.
Okay.
And sponge, sponge we use?
Yeah.
They burn it without oxygen, so it becomes black. And then tantalum hydrochloride gas is thrown over this black sponge that gets deposited over it, and that is the tantalum. That's the tantalum hydrochloride gas is thrown over this black sponge. Having said this, selective laser melting technology has come now, and it is going to change our knees and hips in coming time. Even you will get your knees also femoral component and tibial component also made up of selective laser melting. It will take some time, 5 years at least, and maybe 10 years to come in India. Having said this, bone ingrowth in tantalum and titanium porous is same. Nothing is better than other. So there is no cause of worry using one or the other.
Yes. It is a macro structure that earlier we used to think that it's actually got tantalum has got osteoconductive properties, but that has been proven wrong. It's only the macro structure, the mechanical properties of tantalum that really matters.
Exactly.
A similar thing we use in the cone, in the bone defect in the knee.
Absolutely, absolutely. Same principle, yeah.
Correct. So I think we are just reaching at the end of the time. On behalf of Dr. Vikram Shah, the Managing Trustee, President Dr. Sharan Patil, Dr. Leo Joseph, Secretary, Dr. Pachore, our patron, my colleague Dr. Dhanashekhar Raja, myself and all the executive members of the ISHKS body. I thank Vijay for sparing your time and giving your valuable inputs on the topic of the acetabular bone defects. You are busy and you still managed to come. At one stage, we got the time that probably you may not be able to make it, but really we thank you for making it. And thank you for all this. To all our colleagues, please spread this message of this lecture to all your colleagues and friends. All the senior faculty is very eminent. They are coming here and giving you the talks on the various topics. The next lecture is on 6th of January. We have Dr. Leo Joseph and Dr. Krishna Kiran that are going to give talks on hip and knee subjects. At the same time, again, I remind all the friends to go for the early bird registration. We have a special packages for the postgraduate students also. The 5th, 6th, and 7th April, Calcutta, we have the ISHKS annual conference. And I can assure you, and I'm telling you, very eminent the faculties from Australia, from UK, from USA, from Germany are going to be there, along with the who's and who of the India, the biggest faculties and the most experienced people from the Indian faculty is going to be there with lots of case discussions, video techniques, live surgeries, and a very nice academic program is being prepared. So please do join, get yourself registered. If any problem you have, please contact us. And I take this opportunity to once again thanks Dr. Nilen and Dr. Vijay Bose, Dr. Vikram, Dr. Pachore, Dr. Dhanashekhar Raja. And next time, we'll be meeting again on 6th of January for the next academic program. Till then, I thank everybody and say good night to you. Thank you.
Thank you. Good night.
Thank you. Thanks.
Hello, yeah. Leave the webinar.
Yeah, fine. Okay.